All right, fantastic. Welcome everyone to the nuts and bolts of telehealth regulations, billing, and revenue capture. And if you were signed in early, you heard us chatting a little bit about our hopes that this topic is still going to be useful, because when we decided we were going to have this topic and this content, it was many, many months ago, and possibly you don't need this information as much. However, a few of my colleagues have said maybe you do. But we are going to take an approach that's a little bit like providing you the resources that you need, rather than going into some of the details about billing, like what modifier do you use. Rather, we will direct you where you need to go if you're looking for that information. So just a little disclaimer and consent. You may have seen that the recording button is turned on. What you share or discuss in chat may be part of the recording. Please know that if you chat privately, it is actually not included in the chat log. We will send the recording for this session and the slides out to all registrants. It usually takes us a day or so to get that out, and we are going to convert the recording link to a YouTube link, so that may take us another day as well. We would love it if you can chat your name, your role, and your organization, and what is the status of telehealth in your organization? What popped up for me was what's in your wallet, so I paused for a second. But moving on, so thriving, this is how we do things now, how exciting, or surviving. Whew, this is hard, we have poor clinician buy-in, the workflows are terrible, the platform is difficult, our patients don't like it, so we're just surviving. We're making it work for now, but we'll be glad when we get back to in-person visits. And if you're not an organization that's delivering telehealth, just don't even add that information, but we would love to see your name, your role, and your organization. We all have to give you this disclaimer, and I can safely tell you that we have zero relevant financial relationships to disclose. Today, we're going to do just a brief overview of the telehealth regs, billing, and revenue capture. We're going to spend about an hour and 15 minutes together. We'll have a didactic session, which may actually be a little bit more than 25 minutes. I have about 10 slides that I'm going to fly through, and then I have some slides that I'm going to slow down a bit on. Those 10 first slides or so are ones that are a repeat if you have attended our previous ECHO sessions. And then Camille is going to do a case presentation from Valor Health. We are so grateful for her being here to present. And then we'll have some time for talking about telehealth and understanding what additional questions you may have. And this is an ECHO session. And yeah, I'm going to be talking nonstop for a little bit, but this is really all teach and all learn. And honestly, our attendees, we know you would rather hear from each other than hear from, a person just doing a didactic. So if you have anything to say, anything to add, we heartily invite you to say it and to add it, either when we get to Q&A or, raise your hand, chat to Sarah, let her know, hey, could you get Trudy to pause, or raise your hand or raise your electronic hand and we'll pause. So it's really all teach, all learn. Our objectives today are really wordy, but basically we're going to, this is geared towards primary care and it is geared towards the nurse role. So with telehealth, there are some new things you need to think about with HIPAA privacy and security. So we're going to touch on that a little bit. Also talk about the contributions that nurses can make to billing and capturing revenue. And we've covered this before a little bit as well. And we're happy to share out our resource that we put together for that previous ECHO. And then think about how nurses can elevate. We're always looking to elevate the nurse role. So we'll touch on that a little bit here and there and in between on the slides. And then again, we always want to weave in improvement science. I was talking to a University of Utah student yesterday morning. He's a nurse practitioner and he's getting his PhD. And he said what he loves about working with CoMagin Health is that we don't have binoculars on. We really think big. And when we're talking about telehealth, for example, we talk about team-based care and we talk about HIPAA and we talk about kind of holistic telehealth. So hoping that comes through today.
And
for definition.
Just wanted to let you know that Camille did let me know she needs to leave at 1. Just wanted to make you aware of that. I apologize for interrupting.
No, perfect. Thank you so much. And thank you so much, Camille, for accommodating our timeline as well. So there's a technical definition of telehealth that's very, very broad. It's an umbrella term. And then there's a very practical telehealth definition, very specific to healthcare service delivery. And then telemedicine really includes both telehealth, that practical definition that we'll cover in 2 seconds, and other virtual services. And then there are that list of other virtual services. So taken all together, they are telemedicine, and there's a list that you'll see at least 2 times over of what are the telemedicine options. And that's not a comprehensive list. There are actually a few things that we could add to that. The most commonly cited telehealth definition comes from HRSA, and it's great. It's comprehensive. This is the umbrella term that I was talking about, the technical term for telehealth. And as you can see by the graphic that we have in the lower right-hand corner, there's telehealth, and then there's telemedicine, which is under telehealth, and then telemedicine incorporates telehealth, that practical definition, and virtual services. Telehealth services, before the public health emergency and when the public health emergency is over, CMS is going to go back to its very, very strict requirements, which require an interactive audio and video telecommunication that allows real-time or synchronous communication between the clinician, who's always at what we call the distant site, and the beneficiary who's at the originating site. So at the end of December, CMS published the 2021 calendar year physician fee schedule final rule. And they had received, after the proposed rule, a lot of folks saying, you know, do we really have to keep both of these components for telehealth, both the audio and the visual? And CMS said yes. So it's in the final rule. They're not going to have any leeway. They have given us a little bit of forgiveness along the way. And Utah Medicaid is not as hard line as CMS is with the use of having audio and video for telehealth. And again, the distant site is where the clinician is, the originating site is where the patient is. If in certain facilities, Medicare will reimburse for the originating site fee. So for example, if you're at a long-term care facility and you are doing the work of, you have your cart that you're pushing around, or you have the device, you're helping the patient and the family get set up for a telehealth visit, that's work that you're doing at the originating site where the patient is. And so Medicare does reimburse a small fee of $27. Back in March, we looked at old telehealth codes, and we actually saw a rural health clinic that in one calendar year had billed enough instances of the originating site fee that they had billed about $20,000. Utah Medicaid does not pay an originating site fee. This is a busy slide, and I'm not going to spend too much time here. So Medicare telehealth services, we kind of have the before and the after and during. So before the public health emergency, there was a smaller set of telehealth codes, which has really expanded to 250 codes. And it's updated every couple months as needed. I just went back to check again to see if they had removed a particular code that they said they were going to remove, which they hadn't. But anyway, the last time that they updated it was actually early December. And so these are some of the allowances compared to before we had the public health emergency. So those are those slides that I said I really wanted to whiz through. So apologies if that was too fast, too much information, but we're going to slow down now just a little bit. So Hipaa and telehealth, it's really everyone's responsibility. I was a clinical manager for 5 years, and I just have to tell you, I had a blind spot about Hipaa. I did not know all of the rules. I did not know that I was supposed to have a security official and a privacy official or officer. They can be one and the same person, but there are certain requirements that the security officer or the privacy officer or the two of them combined have to do or have to attend to, including, for example, making sure that everybody is trained. So with telehealth, there are 3 things very specific to the HIPAA privacy rule that seem to be coming up over and over and over and over again. So a lot of times a clinician or even a patient will be holding a telehealth visit and they will be using the mic on their computer. If you're using the mic on the computer and you don't have a headset and you're a clinician, everybody in clinic who's within earshot can hear the conversation. And clinicians are not in the exam room holding their telehealth visits anymore. They might be at home. So this is a huge danger for violation of patient's privacy. So, you know, my husband shouldn't be hearing my visit with my patient because I have the mic on and I don't have a headset. The same is true for patients. Patients are taking that call, and anyone in the household, if they are on mic, can hear that conversation and they don't have the privacy. And we often are concerned, especially for patients who might be in abusive situations where they can't actually talk and be honest. You know, they don't have the privacy that the clinic exam room provides. So it's a good idea to make sure that you have a headset or earbuds on if you're a clinician. And there's not a lot you can do for the patient side, but you can ask if they, have earbuds that they can use. Maybe instead of plugging into the computer for sound, you know, is there an option on your telehealth platform for the patient to call a number, just like you guys had the option to signing into this Zoom? So there's also the minimum necessary. So, you know, we work with a variety of healthcare organizations. And for example, if you're at a long-term care facility, which maybe because mostly if you are from primary care, that's not the case, there's record sharing. So if a clinician doesn't have access to your EHR and they are providing telehealth services, sometimes you have to send them patient records. So just remember that the privacy rule has the minimum necessary rule. So if somebody is going to be seen for a sore throat, for example, by telehealth, do you really need to send everything like their colonoscopy? Really keep it to the minimum that clinician needs to have. Even if you're a primary care practice and you have a specialist who's doing telehealth and you might actually be the originating site. So these are the three things that we're seeing coming up about the HIPAA privacy rule that are specific and kind of new to telehealth that we hadn't thought about before. So it's everyone's responsibility. So everyone on the team, if you're a nurse, if you're an MA, if you're reception staff, everyone should really be thinking about the HIPAA privacy rule. The security rule and telehealth, there's a lot around devices. So you're carrying around iPads. We were talking to a rural health clinic that takes a device that they have nursing staff who actually will take the device to the patient's house. So if that device is not secure and, the MA or the nurse leaves it in their car or in their vehicle, leaves it in the patient's home, it's possible that it could get stolen or somebody could access it who shouldn't. So it's with telehealth, just think about the devices that you're using and make sure that they're password protected, make sure you have antivirus software, make sure they are physically secured. In my practice, we had tablets that we had to put them into their battery charging, but at night, it was one person's responsibility to take them out of their battery chargers and put them in a room and lock them. At other clinics that I've worked with back in the day when we could actually go on site, they have their devices kind of locked down with cables. You would be surprised what disappears and how things disappear. So we're walking around with devices a little bit more. We don't have a secure, we don't have a computer actually in the exam room that's tied down. Terminate session. So if you're on your computer and you're not doing something, it kind of shuts off. So make sure your telehealth devices have that. Ensure that you have encryption and decryption on your device as well. And the other thing is inventory. So every healthcare organization is required, or healthcare entity is required to do a security risk analysis. And a lot of these recommendations come from exactly the security risk analysis. And part of that security risk analysis is having an inventory of anything that transmits, stores, or creates electronic protected health information. So just make sure that if you're getting new tablets, that it's in your inventory. If you have a clinician who's using their smartphone for patient-related work, you want to make sure it's part of your inventory. Make sure you have security awareness and training that includes telehealth related concerns because it's new. So however you're doing your security awareness training, make sure you build telehealth into it. And we should all have HIPAA compliant platforms. I know there's a waiver. It's okay. We can do telehealth without a HIPAA compliant platform, but that's going to go away soon. And you always know you have a HIPAA compliant platform if your vendor agrees to sign a business associates agreement. And then specific to Utah says, okay, fine, we understand that you may not be using a HIPAA compliant platform because we're right now doing what we can do to enhance access and keep patients safe. But if you're not using a HIPAA compliant platform and you're doing telehealth, you have to let the patient know that it's not HIPAA compliant. You have to give them the option to decline. And then you have to take reasonable care to ensure privacy and security. And my recommendation is just document that you did those three things. If you're seeing a patient under Utah Medicaid, something as simple as like, we're doing FaceTime because that's what works for the patient, and just say the patient was advised that FaceTime for telehealth is not HIPAA compliant, but they still want to proceed with the telehealth visit using this platform. And we, took all efforts to ensure privacy and security. So I think that's enough about privacy and security. Sarah, if there's anything in chat, any questions, let me know, because I can't really see chat right now.
We don't have anything in chat at the moment.
Great. So the other thing we wanted to cover is, especially for nursing staff and other ancillary staff, the care team, what can we do to ensure we keep patients safe? So with telehealth, there's this, it's not like the kitten in the picture. It's really keeping up a lot of people at night. And prior to the public health emergency, there were very few, possibly I think it was only one malpractice suit because of telehealth. I think we're going to see a bunch more. And my concern is actually that we are abandoning team-based care. So prior to such high use of telehealth, we would engage in pre-visit planning, huddles, identifying and addressing gaps in care. And as I work with healthcare organizations, that's really just fallen by the wayside, especially in the rural health clinics and the FQHC/health centers, because they're not actually using the telehealth codes. They're not doing the audio and the visual. What they're doing is using the telephone E&M code that CMS stood up during the public health emergency. And they're just doing the phone call, and nursing staff and MAs are not part of that workflow. And so I'm a little worried about that. The number one reason for malpractice settlements is missed and delayed diagnoses. And if you're not doing pre-visit planning, for example, and addressing, for example, if somebody's due for colorectal cancer screening, by the time they come to you in person and you're doing your workflows again like you should, it might be too late for some people, or things may have progressed. The other concern that people have is when is a telehealth visit appropriate? So at your organization, or if you're a nurse or an MA or anyone else on the team, it's really helpful to know what the protocols are for when we will see somebody in person versus a telehealth visit. If somebody calls and they say, I have crushing chest pain, we're going to be telling them to call 911. So that's an obvious one, but some of them are a little more subtle. The American Telemedicine Association website has some of these protocols, but usually your medical staff, they know what we can do by telehealth and what we can do in person, but those protocols should be written and available for everyone, especially nursing staff. The other thing that I think keeps people up at night is, if you see a patient in an exam room, if they crump on you, you're there. You've got the personnel to do CPR. But if you're on a call with a patient and they start to crump, or you see them lose consciousness, you need to know where they are. So capturing where they are before the visit starts, that is something that nursing staff or other people on the care team can make sure and document in the chart. Sorry, I was thinking about an example. So I had a patient that I called. This was, many, many years ago, probably 10 years ago. And I was talking to my patient, and I realized he was suicidal. And he told me that he had taken aspirin. He had like down a whole bottle of aspirin and other pills. I wasn't sure. And I tried to cajole him into telling me where he was. And eventually I did get it out of him. And I said, I need to take another call. And I called 911, and we saved his life. And I ended up seeing him in the hospital after that. But, this is something that shouldn't happen to anyone else. Just have a high index of suspicion of knowing where they are. And as I mentioned, missed and delayed diagnoses. So identifying and addressing preventive and chronic gaps in care. I was talking to a provider yesterday morning, and I was actually surprised. This doesn't happen very often, but they are on paper. So kind of identifying and addressing gaps in care. I said, so, you're on paper. If you have that face sheet, like on that left side of that chart, that you can do pre-visit planning for, and have your nursing staff talk to the patient about what they're due for, get them scheduled if we can. I know a lot of care is delayed with COVID-19. Make sure we continue to close the loop on referrals, tests, and community resource referrals. So my husband just had a test, and they actually wanted to see us in person because they said we don't give test results over the phone. And we begged them, and he was able to say, my wife is a clinician, can we please do it by telehealth? And so they relented. But make sure that things like closing the loop on tests, making sure that patients get the answers or the results of their test is really important, especially in the telehealth world. And think about, how can we have, so I talked early in the COVID-19 pandemic, I talked to Dr. Shoma Stout, and she had this vision of how do we have a wraparound virtual team-based care? And that is where nurses and MAs and other support staff really shine. Like, what are the new roles and responsibilities? I work with a health center who has eliminated the reception role in the telehealth workflow, and the nurse, they actually use LVNs, not LPNs. The nurse and their MA has taken on the receptionist role, and they have used the receptionist for making outreach calls around population health management because they were behind on those. So is there anything else that keeps you up at night around telehealth and patient safety concerns? We talk about all teach, all learn. If you guys are at the front lines, what else are you seeing that keeps you up at night?
Feel free to unmute yourself or chat in.
Hi, Trudy. It's Brenda Luther. I'm from the College of Nursing. What keeps me up at night is teaching all this to the students. You've done such a great job. These are things that I would have not thought of. I mean, your clinical expertise shows so well. The patient side of this is truly vital, and you can see this happening with everyone gearing and quickly flipping to telehealth. The whole team care. When you said we lose the team, we stop team-based care, you caught my ear, and I thought, well, how do we just do that from telehealth? Wait a minute, we still have the whole team there. And you well described it. Just had to throw in that comment. So I'm not kept up at night about what to do for the clinicians. I'm kept up at night about what to do for the students. So that they're getting it.
Thanks for that comment, Brenda. Hey, this is Danelle Pendergrass. I'm eating, that's why I'm not on camera. Don't want anything in my teeth for you guys all to see. But I was really concerned about the team-based care when we implemented telehealth. And so we're doing that, but what keeps me up at night is the seamlessness of the telehealth programs that are being developed to be able to see one clinician, two clinician, three clinician, four, to keep that all on one level to more simulate what happens in the office so that we can have that team-based care. So I guess it's the technology that's being developed is what keeps me up at night to ensure that we do have team-based care.
Yeah, for sure. Thank you, Dr. Pendergrass.
anyone else like to chime
All
in?
right.
We have from Christine, I worry about how people do not have access to technology, and so phone is the only way to go.
Yes, and I'll cover it in a bit. So, for the public health emergency, CMS allowed the telephone E&M code, which I believe they're reimbursing $92 for. And so in the proposed rule, a lot of people said, we have access issues, we have equity issues with people having devices, with having internet, with having broadband. So what are we going to do? Are you going to keep this this telehealth code permanent? And they said no. But they did offer something else up. And so the virtual check-in, that's usually 5 to 10 minutes, they added a code that now allows 11 to 20 minutes. So, at least that's good. But it's not, the reimbursement is going to be a lot less. It's hard to tell. It's not, that code is not actually on the physician fee schedule lookup, but it is going to be equivalent to a different CPT code. And when I look up that CPT code, it's about $70. So team-based billing and revenue capture, like where can nurses fit in? U equals an expert. Like, and I did not have this expertise. I had a strong clinical background, operations, practice transformation, quality improvement, process mapping, et cetera, et cetera. But I think telehealth is so cool. And so I have read and have file folders and notes. You can be as much of an expert as I am. Really, you can. And I really feel as though we have two jobs. I have my job and I have making my job better. That's my second job. And if you are a nurse in primary care, you can become the resident expert that everybody goes to. And it's going to look really good on your resume. So, know what the telehealth and other virtual service options are for your patients and your role in providing those services. For nursing staff, there is so much that you can do. And in the most recent final rule, oh my goodness, CMS really kind of lifted a lot of the constraints around incident to. So for nursing staff and other clinical staff, they didn't really loosen things up. What they clarified, what they meant was, and by that clarification, it really makes it clear the important role of nurses and other people on the care team to provide holistic care. So, start small and expand your knowledge base. So maybe you learn just about telehealth and not the other virtual services, or you say remote patient monitoring. Whoa, that's the one that really cuts down on costs. Keeps people out of the emergency department, admissions, readmissions, because that reduces per beneficiary cost. But you know what? It's also something that patients really like as well, because nobody likes to be readmitted. So maybe start small. Say, I'm going to learn remote patient monitoring inside and out. I bet that if we have any nurses on this call, you probably already know chronic care management and principal care management already. So you're already a quasi-expert, if not, a full-blown expert on telehealth and other virtual services. So, and lucky you, Ta, you have two telehealth resource centers. You have the Northwest Regional Telehealth Resource Center and you have the Southwest Telehealth Resource Center. Their coverage kind of covers you along with the other states that they cover. And if we have time, I'll show you a resource. The state of Washington just required that unless you are an MD or a DO, you have to go through telemedicine training. And the Northwest Regional Telehealth Resource Center developed that training for Washington providers. I took it this weekend because I was curious, and it's really well done. And it's concise. It's not like super duper wordy. It's easy peasy. I just loved it. And they are developing one that's going to be more general. I think they're going to be calling it Telehealth 101. But I'd say that Washington training is good for anyone to go take. So a lot of words on this slide, but for the new and established E&M visits for 2021, clinicians can either bill using medical decision-making or time. And in that time can be reviewing charts, it can be the contribution of clinical staff. So I feel that now, starting in 2021, we can truly have team-based care, kind of E&M, or those office visits. And of course, you can do those by telehealth as well. Advanced care planning, honestly, nurses are better at doing advanced care planning, I think, than clinicians. So there's a huge role for nurses. And you can see that the reimbursement is awesome. I mean, this is reimbursement that you can bring into the clinic. And we've included links to the fact sheet and FAQs. If you want to become that expert on advanced care planning, personally, I would go through my entire panel of patients, look at anyone 65 and older who doesn't have advanced care planning done and doesn't have advanced directives, and I would get that taken care of ASAP, because because what if they come down with COVID? You know, their end of life decisions may have changed. They may have said, you know, I want to be do not resuscitate, do not intubate, or DNR, DNI, but they may say, oh, wait a second, I will take a ventilator if I have COVID. So, you know, now is the time to you know, really do advanced care planning. Transitional care management, again, our RNs do better than the clinicians. Transitional care management should be a team-based affair, but the reimbursement is huge, as you can see. And I heard that CMS is going to bump up the reimbursements for 2021. I checked on the tool a couple days ago to see whether I could update these rates, but no, these rates are still in place. So maybe check in April. Screening and assessment services. So we put a link in there. And so the reimbursement is small, it's $5, but at least it's something that you can do. Annual wellness visits, again, Co-Managed Health has worked with a lot of practices around getting annual wellness visits in place. And we work with a lot of RNs and other nursing staff and MAs. You know, you can be a specialist, you can have the annual wellness visit program, and you can own it. Chronic kidney disease patient education, that does require a little bit of specialized education, of course, and a counseling visit to discuss the need for lung cancer screening with using low-dose CT scan. We need to be better about lung cancer screening, and I think that nurses can lead the charge, even though they may or may not be able to do that counseling. And then the 3 new opioid use disorder codes that were as of 2020 are another place, I think, that nurses can maybe not deliver the services, but they could be in charge of the program and ensure that these billing codes are used and services are delivered. The telehealth.hhs.gov is a really great resource, and I'll show it to you in a second if we have time. I'm really keeping my eye on the clock for Camille, and I'm only going to talk for about another 5 minutes, and no matter where I am in the slides, I'm going to hand things over to her. But the Medicare Telehealth Payment Eligibility Analyzer. So before the pandemic, you could go to this particular website and you could put in your zip code, and it would tell you whether you fulfilled the geographic and health professional shortage area requirements to receive telehealth as a patient. I checked it, I don't know, probably around June or July, and the site was down, which I thought was interesting. And then it was back up again. And then I went to it again and checked it out, and it's gone. The website is called Medicare Telehealth Payment Eligibility Analyzer, but you go to it and it's completely different. What I'm hoping that signifies is that they are planning on lifting the geographic and health professional shortage area limits for delivering telehealth. So just a quick word on that. We will also look at these resources, the Utah Medicaid COVID-19 emergency guidance. These links are live, so when you get these slides, you will be able to go to these links. We also have a resource roundup Word document that we'll send to all attendees with all of these links. So you don't have to worry about, that you might miss out on a really great link. So I think what I would like to do, I'm going to be showing you these resources. And I think what I'd like to do is turn things over to Camille, and I will come back to this slide, other virtual services, when she is done. I want to give her ample time. I don't want her to have to rush at all. So if I'm gonna go through slides really quickly to get to her slides. So if flipping slides bothers you, avert your eyes.
Well, and Trudy, I did let the group know that we will take their questions, and there are a couple after Camille presents so that she has time to present her case.
Okay, great. I'm going to turn it over to you, Sarah, to introduce Camille. And Camille, I will flip your slides for you. Just let me know when you're ready to go to the next one.
We want to take a minute to thank Camille because we didn't give her much notice, and she stepped up to the plate and said that she would be willing to present a case for us today. So I'm going to turn it over to Camille Evans, who is with Valor Health in Emmett, Idaho.
Well, thank you. Sorry about the time mess up. So I am a behavioral health consultant here at the primary care clinic for Valor Health. I also Valor Health has primary care clinics in addition to being a critical access hospital, so I serve as their social worker also. And so we have been working on integrating behavioral health into our primary care clinic, and we are about, if you're not familiar with where Emmett is, we're about 25 miles from Boise. There's a large hill that divides us, so sometimes getting care outside of the community can be hard, especially for people who have transportation needs or when the weather gets bad. And so telehealth has been a great option. You can go ahead and go to the next slide. So I was excited to hear one of the things talked about was team-based care. So that's pretty much what this is about. It's how do you do a warm handoff, which is something that we do on a regular basis in clinic as part of integrated behavioral health. And so how do we do that via telehealth? So go ahead and go to the next slide. I think the other details on this. So a physician will see a patient and then determine that there is a behavioral health need or something that I, as the behavioral health consultant, might help with. And in the clinic, they would just come grab me, and I would go in and do a quick visit with the patient and then set up any additional follow-up that needed to happen. So using telehealth, that has been difficult. We initially were using Zoom, and that was really difficult for our patients to be able to navigate. And on Zoom, we were able to have me call in as a third participant, but still the flow of that was really difficult. We never really quite figured it out. And then we are now using DoxyMe, which does not, the version we have doesn't let us add a third person. So the only way we've been able to do it is just happen to reschedule with the patients to come back in and talk to me, but then we lose that opportunity many times because either they don't, we're not able to get that other visit to happen, or, you know, they're just, it's better to capture them in the moment. Go ahead, go to the next slide. So I would love to hear other processes that other clinics have been able to come up with that's been effective. I think that these things can also be beneficial for if you have like a chronic care manager in your clinic and you're doing a warm handoff. So any type of team-based care, this does not have to be specific to behavioral health, but how do you do that team-based care in a telehealth visit?
And we'd love to hear from you who are doing this, what you're doing in your clinics.
Hi, this is Danelle again. Camille, I'm so glad you brought that up because that's the part that drives me crazy. So we're not able to do it on our telehealth portion, but if we call them on the phone from our work from home phone things, we can do what's called a warm transfer. And so we can tell the next person, like, this is what's going on, and then hand them off. But I have yet to find a way to do it with the telehealth. So that's kind of hard too, if somebody's on their phone doing the telehealth and then we're calling and transferring. It's a little bit of a mess. So I'm so interested if anybody's doing anything else out there.
Anyone else? Sounds like this might be a problem for everyone, Trudy. Advice?
Yeah, we keep realizing that it's, how people say location, location, location. When it comes to telehealth, I feel like I keep saying workflow, 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 because it trips us up like this. It's a really good point. I like the idea of, so Camille, if you had somebody on DoxyMe and you needed, and a clinician needed to hand off for behavioral health, would it be acceptable to do what we heard just a minute ago and end the DoxyMe session and call the patient on the phone? It's disruptive, but would that be an option?
Yes, and that's primarily what we've done. The physician will end the visit and then, come find me and say, hey, will you give this patient a call? There's always then the risk of I can't get a hold of them, and so I think it's the best we can do in this situation. With the platform we're using with DoxyMe, the only other option is having the patient hang up or disconnect from the visit with the physician and then put in my URL and connect with me, just kind of doing a whole new telehealth visit. But we get a hard enough time to get them connected the first time. So it can work, and it has worked with a few people, but it's challenging. When I do have a follow-up visit with a physician or with a patient and the physician is also seeing them, I'll usually just set it up in my office and the physician comes in my office and sees the patient, that way, and they leave and I complete my visit. So it works if it's scheduled to do it that way, but when it's just that warm handoff, that's the point that we haven't been able to figure out.
And when the clinician steps in, whatever device that you work on, you can't, you're kind of stuck not being able to work. They always say if wishes were horses, beggars would ride. But if you had enough devices like iPads, you could literally physically hand off the device and say, here, will you continue seeing this patient? And then you could go back to a different device. For me as a clinician, it would drive me crazy, and I'm sure it drives you crazy too, to just have to give up your computer or your device or whatever you're working on, and until the patient's needs are met, and whoever is talking to the patient ends the call. I think it's an interesting conundrum.
Yeah, I do. I like that idea, though. If this is something we are wanting to continue to provide long term, maybe moving to tablets for the telehealth visits, so that you could literally carry the patient to the other person. Possible solution. I don't, there's other barriers with that too, but.
I just have a question. Yeah. Trudy, is there like a repository of all the different types of telehealth systems and their capabilities? You would think that somebody would have had to thought this through and are possibly capitalizing on what people need to do this type of care. Is there any like certain place we can go to look for that?
Yes, I think so. So there is, I can't remember if it's, I can add it to the list. Yes, there is. It's like telehealthtechnology.com or something like that. I think it's part of if there's anyone from the NRTRC on the line, you'll know what I'm talking about. I've been there, they've been there, that link to that, whatever that source is probably there, but it's all about the technology. And it's a really, really great site. I will add it to our resource roundup. You know, but sometimes you're on your own kind of checking into things. Like doxy.me, like I have just learned over time that it doesn't allow third party, because we talk a lot about being able to have patients and family join calls, especially if you're in a long-term nursing facility. You know, but how do you know what works and what doesn't? I will also say that our Patient and Family Advisory Council has told us that doxy.me is easy to use. So let me make a note. I will add that technology link to the resource roundup document that we have.
Anyone else have any input? Trudy, we want to thank Camille for this, because, you know, this is definitely a very timely issue. And I kind of liked your idea about, you know, using the tablets. We heard that from one other provider in one of the sessions where they talked about, they actually do their visit in a patient room, in one of the rooms in the clinic, so that there is that privacy. And that would also make it possible to do that handoff fairly easily. So I really like that idea. So thank you, Camille, for taking the time to present, and we really appreciate your input here. Camille did have a question that I wanted to get answered before she has to leave us. She asked, with the advanced care planning visit, it said that the RN can do portions. So does the provider need to also be part of that telehealth visit to be able to bill it?
Yes, so look at the resource carefully. You know, it has to be billed under the NPI number of a clinician, of course. But the resource the link that we'll send that's in the slide gives you guidance on who can do what parts. Camille, I thank you so much for joining. And oh, by the way, I also talked to Valor Health about telehealth maybe January 6th or something like that. So I spoke to Ruby Cash, your clinical informaticist, about what you guys are doing with telehealth. And I love that you are, you know, constantly working on workflows and trying to make telehealth better and supporting your clinicians. So, you know, hats off. And thank you so much. This was really great to hear what you guys are doing, right? And what you're kind of struggling with the handoff.
Well, we had a comment from Ruby saying that the paid version of DoxyMe does allow for multiple providers, she thinks, and it's a group version. So that might be something to explore too.
Yes. Thanks, Camille. That was perfect, says Dr. Pendergrass. All right, I'm gonna take us back to where we were. We're kind of going through the resources. The virtual check-ins. So I saw a question in chat, so this may answer that question. So the virtual communication services, I was so excited when these were available starting in 2019, and I talked to my clinics and I was like, guess what? You can get paid for telephone calls now. They were like, what is the reimbursement? I said $14, and the response I got was, meh, it's not worth it. So during the public health emergency, CMS has bumped up the reimbursement, so it does make it just a little bit better. So you can do that 5 to 10 minutes and get reimbursed about 25 bucks. And I told you there was a new code that I wasn't sure about what the reimbursement is. So it's added on an interim basis, so it's only for calendar year 2021, but it is responding to people who said, we need a phone option. Do not take away our telephone E&M option, which they are going to do. But there is a new code for 2021. So anything in the blue font here is new as of that final rule. So there are new codes for 2021 to be used by a qualified healthcare professional who cannot report evaluation and management services. So to me, that says clinical staff. So yes, I do think there's an option for, there is actually, for using the virtual check-in by an RN. And, you know, oh, by the way, so RNs, just like in clinic, so unless you're at a health center, which this is, you know, you can't do it if you're at an RHC or a health center, nurses can do 99211s as telehealth. It's a telehealth code. It's something that nurses ordinarily do, RNs do in the outpatient setting. 99201, which is the, as long as I'm not getting them confused, 99201 was eliminated as a CPT code. It's for the new patient, kind of the lowest E&M code for the new patient. And for starting in 2021, that code no longer exists, but the 99211 is still available. So, you know, I think the virtual services one is something that we're not seeing very much uptake on, and CMS looks at the uptake on certain codes, and if they want us to use those codes and they're not being used, they'll increase the reimbursement just like they did for transitional care management. But if people are not using those virtual check-in codes, you know, I'm afraid they're going to go away. Remote physiologic monitoring is an amazing option for remote service delivery. It has the most evidence of all of the other virtual services for reducing emergency department visits, admissions, and readmissions. It's really great for patients too, because we only see them for, you know, what, less than an hour or two, all told, for a year. There's like 3,000 plus hours during the year. The rest of the time, patients have to be the experts and do self-management. And so remote physiologic monitoring or remote patient monitoring is an option. And there is fairly decent reimbursement. Not if you're a rural health clinic or a health center. CMS will not reimburse for remote physiologic monitoring. Unfortunately, they say those services are included in your all-inclusive rate. So a little disappointing because the evidence is so strong. The chronic and principal care management was added to the chronic care management starting in 2020, and starting in 2021, CMS opened up principal care management for rural health clinics and health centers. So we should be able to provide care management to our patients, you know, even if they have one acute condition or two chronic conditions. This is really a leverage point for RNs to kind of own and get going the care management program. And I will say that in CMS, the chronic care management is more about care coordination and chronic disease management, and it's not what we think about when we think our top 5% high need, high cost patients in primary care that really need an RN to take care of. The chronic care management codes, you know, I work with a lot of practices where it's an MA or an LPN who's actually doing chronic care management. Principal care management, I'd argue that maybe a nurse, an RN should be doing that. The behavioral health integration is basically like chronic care management, only it's for behavioral health conditions, and it is underutilized. The it's a psychiatric co-management, is not often available because it does require somebody in psychiatry with a degree in psychiatry who can prescribe medications. And I'm hoping that we're going to have creative ways to make that possible. But for now, it is what it is. The telephone evaluation and management services is great, but only for the public health emergency. E-visits are online digital evaluation services. So this is a meeting with the clinician and the patient using the patient portal, and I see hardly anybody using it. The interprofessional consultation code is, there's one code for the referring clinician, the other codes are for the specialist. But if you need a specialist because you're in a rural area, letting them know about these codes and asking them you know, you're in the state of Idaho. We don't have a neurologist here where we are. You know, could we maybe talk about doing some consults and applying these codes which fall under virtual services? We do know that a lot of healthcare organizations are developing their own cheat sheets. So, you know, what is the insurance, and, you know, what for what code, you know, what do we have to put it in for the place of service? So for, I think, all telehealth, not for the virtual services, but for the telehealth visits, that discrete set of codes from CMS, you usually are using a place of service code 2, which indicates that it's a telehealth service. But know who reimburses for what, and if they reimburse at parity, so at the same as an in-person visit. So usually CMS and Medicaid reimburse at parity, but individual insurers may not. Most of them have kind of been, let's call it, shamed into reimbursing at in-person rates during the pandemic, but that's not always the case. Make it easy to bill correctly using a cheat sheet. So when I was practicing, we had a biller who would kind of check my work, but I was responsible for entering my CPT code, entering my primary, secondary, and, you know, tertiary, whatever diagnosis. Just make it easy, because I'll tell you what, most clinicians do not have practice management training in their curricula as they are being trained. And so we have to make cheat sheets for them. But, you know, I just, you know, I see clinicians when we ask them, you know, what's the copay? Do you do remote patient monitoring? We just kind of like shake our head and go, I don't know that billing stuff. Yeah, I don't know. We can make it easy for them to answer those questions and not just kind of shake their head and go, yeah, I have no idea. So, you know, that can be an RN function, creating those cheat sheets. And then workflows, and entering templates. So if you're doing chronic care management, for example, there are a lot of requirements to bill for those 20+ minutes a month. You know, make it easy, create a template in your EHR. So training and track and measure, of course. And remember, I told you were going to see that list again. So that telemedicine options, those are the things that you want to make sure are on your cheat sheet. This is the resource that we have that we sent out previously. I think I need to make sure I know I updated some things to the final rule, but we can send it out again if it's helpful. I'm going to whiz over consent. Consent is, you know, we should not be having our clinicians obtain consent because you don't need a medical license to do it. This is what the team should be doing and documenting. For consent, it's pretty easy peasy. You can get it verbally from the patient. You just have to document it in the EHR and let them know that this is a telehealth visit and that there will be deductible and co-insurance amounts. Patients, we may have a telephone E&M code. Patients don't understand why we're charging them for a telephone call, or why they have to pay a copay, or why they have to pay a deductible. We need to tell them upfront and have cost transparency. It's the right thing to do. It's person-centered. Utah consent is complicated. You know, there's a chance here, an opportunity to digest this and create a template in the EHR that makes it easy to obtain and document. We want to make sure we don't forget about quality improvement and measurement. So I worked with an RN who was very insecure about her value to the clinic. And I kept telling her, we couldn't function without you. You do so many things. But I had to create a spreadsheet to capture all of the billing that she brought in, or all of the billing opportunities that she captured. So for example, if we did a UA or a blood glucose finger stick and we documented the results in a structured data but didn't bill for it, she would keep track of it. So whether you're insecure or not, if you feel like you're ever going to have to answer about the value that you bring in, you can look at the codes that you bill, that you participate in, the reimbursement captured. Look at the quality measures, because let me tell you what, we are going to see them tank. We are seeing them tank. Our colorectal cancer screening rates are just terrible these days. I worry what that really means for individual people. Patient staff experience and satisfaction. We're putting together a toolkit for the University of Utah, and we have some some questions, happy to send them out if anyone is interested. Cycle times, oh my word, cycle times are so challenging to measure with telehealth because often clinicians won't close their visit. So if they don't get the patient on the phone or they don't connect for them, they'll sometimes try it later in the day when it's way past the patient's appointment time. And so that visit encounter in the EHR is not closed. And so you have these cycle times that are like 4 hours long. So it's an opportunity to improve, but it is something that really, really matters to patients, and keeping your eye on ED visits, admissions and readmissions, especially in COVID time, and oh, so much more. So, broad takeaways is really complying with HIPAA privacy and security, especially because we have new things we need to worry about with telehealth. It's everyone's responsibilities. You need to know the rules. Claiming ignorance is not a reason for getting off the hook if you have a breach and you have the Office of Civil Rights at your clinic doing an investigation. You are an expert and you can be a telemedicine expert. It's not rocket science. It just takes patience and chasing after resources and starting small and just building. And before you know it, you will be amazing. And RNs are awesome at looking at how to make things better. So they watch, they listen, they anticipate other people's needs, a special breed. And when it comes to telehealth and just workflows in general, this is the leverage point. Pay attention to the workflows, make suggestions. It's really our frontline staff who come up with the best ideas to improve workflows. So I'm going to do a time check. I'm going to pause for questions. And if we still have time, then I'll take you on a little bit of a sachet around some resources.
Trudy, we did have a question a while back from Danielle, and I think you may have answered it, but I'm going to ask it just to make certain that we get Danielle's question answered. She asked if nurses can bill for the virtual check-in.
No, maybe for that new code, but for the, I think it's G2010 or G2011, that has to be a clinician. And that call, the virtual check-in, CMS put those together specifically to head off an E&M visit. So if you can handle something by a phone call so that the patient doesn't have to have an in-person visit or a much higher charge, this reduces per beneficiary cost. It's also person-centered. So if you can do something on a phone call rather than having the patient come in, they want you to use it. I remember that back in the day, well, it still happens, but we are still in a fee-for-service world. And so, instead of calling patients with their test results, we used to make them come into the office because we could bill an office visit. I think we have less and less tolerance of that these days, but a virtual check-in is really supposed to be to ensure that we avoid an office visit, whether it's a telehealth or an in-person visit. But we will also, in that sheet, we'll update it with the final rule codes if they're not already in there. And the answer will be there as well, Dr. Pendergrass.
Thank you so much. It just seemed like a perfect code for an RN to call, give lab results, check on somebody, whatever. So I was hopeful.
Yes.
Other questions?
Comments, ideas. You all have the best of ideas. You have amazing experience on the call. All right, in case you're thinking, let's just take a quick look at some of those resources. Remember I told you about the telehealthhhs.gov. I really like this site. So they have a section for patients, which is really well done. It has some videos, but a lot of practices are looking for patient resources, and there's no end to them out there of varying quality. but here's a nice kind of standard way to get some nice resources for patients. I'm not sure how you can link it on your website. However, that's a bit of an issue. For providers, there's this getting started with telehealth, and there's a bunch of resources here, and a short little video. And I wanted to point out, look at this, the Northwest Regional Telehealth Resource Center. Quick Start Guide to Telehealth is here, and I just thought that was so impressive. But they have some nice resources. It's not overwhelming, and they're just really kind of clear and concise. I really like having clear and concise and not a lot of what I call TBU, or true but useless information. So I really like this site. I think it's very helpful. This is one of our favorite sites because you can click on any state and you can drill into the Medicaid statutes. I go here all the time. So if we click on Utah, all of the kind of bits and pieces related to telehealth and other virtual services comes up here. So you can see that it says Utah Medicaid reimburses for live video telehealth and does not reference store and forward modality in their policy. So that store and forward piece is taking a picture and then sending it to a clinician. So they, you know, you can't really tell. It looks like they don't. You know, sometimes if you actually call and ask them, you can find out a little bit more. Geographic limits, there's store and forward. You see there's no information, so you can see no reference found. But here, tests must be ordered, provider limitations for remote patient monitoring. Tests must be ordered by a neurologist, reviewed and interpreted by a cardiologist. And here's what I love about this website. So if you are truly going to become that awesome telehealth expert that I know you can be, they provide links to the Utah statute. So if you want to read and say, well, what exactly does Utah Medicaid say? Or if you're putting together a resource and you want to cite your source, it's all here. It's just so easy to find. And I'll often do Control F and I'll search telehealth or remote patient monitoring. So this is one of our favorite sites because, you know, unless you know exactly where to go for the Utah statutes related to telehealth, this just takes you directly there. It gives you kind of a drill down to there. Utah Medicaid also has this amazing website. You'll see again, the Northwest Regional Telehealth Resource Center is featured here. But down here, they have, you know, we're really talking about billing and reimbursement. So billing reimbursement guidance from payers. This looks awesome, like, oh, I'll find out about Aetna and Cigna. But no, this doesn't really give you a whole ton of information if you click on it. But most of the payers, if you go to their website, they know you're kind of desperately seeking telehealth information. It's usually easy to find the information that you need. But what I really liked about this Utah Medicaid dropdown is that it's really a list of FAQs, which I thought was excellent. I wish I could save it to PDF, but I can't. I think, you know, maybe I would be able to copy and paste it. But it says what types of services, can it be utilized statewide? To be reimbursed, do I have to have video and audio? And they say, no, while we really want you to use video, if you can only pull it off using a telephone call and it's clinically appropriate, we will reimburse you. So this is, I love this. This is great. There's one more resource. So this is one that's also on our resource roundup. It's only 19 pages long. There's another one that's 42 pages. But this provides additional billing information. So modifier, you know, who needs to use the modifier CR, who doesn't need to use the modifier. If you don't do billing, you know, sometimes looking at these types of detail can be a little painful, but those are just some of the resources, and we will include, we already have a resource roundup sheet for you with a ton of the resources that we discussed today. So anything that we discussed today is on the resource roundup, and then a few other things are on here as well. And I am going to stop sharing.
Trudy, did you want to talk about the upcoming ECHO for our GWEP folks? and that we will be having a final echo.
I think you're well on your way to discussing it yourself, Sarah. You're doing a great job.
Adrian, I'm going to turn to you because I'm not sure of the date for the
Yeah,
next
so I
one.
put in chat. I hope you can hear me. I'm having issues with my sound today, but I just put in chat that next month we're switching gears to start talking about all of the information that we've covered in the past 3 sessions, but as it relates to the long-term supports and services settings. So, you know, that first session will be a deep dive into those practical strategies, leveraging telemedicine and virtual services to enhance access and improve healthcare delivery. That will be on the 18th at 2 p.m. Mountain, and I put the registration link in chat. And that will be the first of our 3-part series focused on information for the LTSS arena. If you have any questions at all, go ahead and send me an email and I'll put that in chat as well. And we hope to either see you all or help spread the word with our session coming up in February. Thank you.
And then we will be doing a final wrap up session in April, and we'll be sending that information out to you. And thank you, Adrian, for sharing the information about the LTSS Echo. We'll leave it open for just a minute if there are any other questions, but we want to thank all of you for participating in these sessions. And I especially want to thank Trudy. She's done a great job, and she is an amazing resource for Comagin and for all of you. We have
Yes, if you have follow-up questions, please feel free. So our last few ECHO sessions that we have done for the University of Utah, I actually have received a fair number of questions after the session. That was usually after I sent out the slides and the recording, and people said, oh, but I had this other question. So if you have follow-up questions, you know, we're here for you.
And you're getting a lot of kudos in chat, Trudy.
Thanks. So thank you so much, everyone. I'm going to go ahead and wrap up our session. We really appreciate your attending. We know everybody is really busy. We know people are distracted. We know people are webinar weary. So thank you so much for your time and attention today. We truly appreciate it. Have a great rest of the week and an amazing weekend.